Hello, everyone. Today, we're so happy to be hosting a live webinar with our dearest doctor, Dr. Haitham Sakr. Dr. Haitham Sakr is an interventional cardiology consultant working at Dallah Namar Hospital. Welcome, Dr. Haitham.
Hi, good afternoon, and thanks for having me again in MedSynapse.
Thank you, doctor. So today we're going to talk about a very interesting topic, which is the hypertension, but we're going to dig deeper with Dr. Haitham about its symptoms, stages, management, and also we'll talk about the latest updates in the hypertension. So I will give to you the mic, doctor, and please go ahead and start sharing your presentation and discussion.
Thank you, Sarah. Anybody who's trying to construct a presentation about hypertension will always have a dilemma. Should I discuss the European Society of Cardiology, European Society of Hypertension guidelines, or the American College of Cardiology, American Heart Association, JNC guidelines? What I tried to come up with is to construct a presentation combining both, digging more into similarities and differences between these guidelines, and finally come up with some recommendations and summary that I feel would be useful not only for cardiologists and even non-cardiology physicians, but also to the hypertensive patients and to the ordinary people as well. So without further ado, let's dive deep into the presentation. Let me share my slide sets with you.
Yes, sure.
Okay, can you see it clearly?
Yes, yes.
Okay, so I don't have any conflict of interest. What are we going to discuss today is the introduction, agreements and disagreements, non-pharmacological interventions, how, when, and where to measure the blood pressure, levels defining hypertension, the ACC-HA versus the ESC-ESH rationale, the hypertensive or hypertension-mediated organ damage, the H-mode, the treatment, and finally a summary. As you can see here from this slide, the persistently elevated blood pressure and hypertension lead to hypertension-mediated organ damage and cardiovascular disease. It affects almost every organ in our body, not only the heart, the kidneys, the eye, and the brain, but also on the level of both the macro and the micro circulation as well. So what are the agreements and disagreements between both guidelines? Both guidelines agree on low sodium diet, adequate potassium intake, exercise, body weight reduction, proper method of blood pressure measurements, the use of home blood pressure and ambulatory monitoring, and the restricted use of beta blockers as first-line therapy. What they disagree on, however, is the level of the blood pressure defining hypertension, the flexibility in identifying the blood pressure targets for treatment, and the use of initial combination therapy, whereas the European Society of Cardiology, European Society of Hypertension guideline recommends it as initial therapy in patients who are having high blood pressure more than 140/90. The American College of Cardiology, American Heart Association guidelines recommends its use in patients who are having more than 20/10 millimeter mercury above their blood pressure goal. So here is a summary of what we have been talking about in the last minute or two. The increased potassium intake, the increased physical activity, optimization of the weight and diet, reduce salt intake and reduce alcohol intake as well, with no smoking, all lead combined to blood pressure reduction and subsequently to cardiovascular risk reduction. High potassium diet has many benefits, include its potassium-induced natriuresis, which is a cyanide-like effect. Each 55 milliequivalent of potassium will lower your blood pressure by something like 7/5 millimeters mercury. It also lowers salt sensitivity, causes vasodilatation, and it has some renoprotective effect, like an anti-inflammatory, antifibrotic, and antioxidants. And it decreases or slows the progression to chronic kidney disease. This has been found in patients who are having optimized potassium level of 4 to 4.5 as compared to less than 4 milliequivalent per liter. These are the summaries of non-pharmacologic interventions, including the physical activity, whether it's aerobic, dynamic, or isometric resistance, healthy diet, weight loss, reduced intake of dietary sodium, and enhanced intake of dietary potassium with moderation in alcohol intake. Most of, if not all of these, will reduce your blood pressure in the range of 5 to 6 millimeter mercury if you are a hypertensive patient, and 2 to 3 millimeter mercury if you are a normotensive patient. However, the healthy diet, including the DASH dietary pattern, which is diet rich in fruits, vegetables, whole grains, and low-fat dairy products with reduced content of saturated and total fats, will even reduce your will further reduce your blood pressure by something like 10 millimeters mercury, especially if you are a hypertensive patient. How to measure your blood pressure? Should be sitting in a quiet area, in a chair with back firmly supported and your feet flat on the ground. Arm is supported, and definitely you would use an appropriate sized cuff. You wait for 5 minutes, then you check blood pressure 3 times, 1 minute apart, but it should be a little bit more than this, maybe 3 to 5 minutes if you have the time. You eliminate the first reading and average the next 2 readings, and this should be your blood pressure at that time. You provide the blood pressure reading to the patient and make sure that you select the proper cuff size as a function of arm circumference. Both ambulatory blood pressure and home blood pressure monitoring has advantages and disadvantages. For the ambulatory blood pressure, it helps identify the white coat and masked hypertension with a better predictive value for hypertension-mediated organ damage and major cardiovascular events. It allows for nighttime measurements and evaluation of nocturnal blood pressure dipping, with measurement that can be done during routine daily activities, as it doesn't interfere with patients' daily activities. It provides abundant information rather than the single measurement session, and this includes also the short-term blood pressure variability. However, it's expensive, not simply available, and sometimes it's uncomfortable due to close measurements. On the other hand, home blood pressure monitoring allows us to identify white coat and masked hypertension as well. It's cheap, easily available. You do the recording in a relaxed home setting, so no distraction, no irritation or white coat hypertension. Patient is actively engaged in measuring his blood pressure with repeated measurement that can be done over a longer period of time with day-to-day blood pressure variability assessment. However, it's unavailable for dynamic measurements, with potential errors if the patient doesn't know how to measure his blood pressure using the device accurately, and the unavailability of information about nighttime, as the patient would be asleep with no availability of measuring the blood pressure at that time. So the ACC/AHA guidelines emphasize individualized cardiovascular risk assessment using the ASCVD risk calculator before defining treatment goals and options, whereas the European Society of Cardiology, European Society Hypertension guidelines recommend the use of the score system, which estimate the 10-year risk for a first fatal atherosclerotic event in the context of age, sex, smoking habit, total cholesterol level, and systolic blood pressure. What are the level-defining hypertension requiring treatment? It's 130/80 in the United States and 140/90 in Europe. Roughly speaking, around 15% more US adults will be defined using these cutoff limits as having primary hypertension. In patients with high normal blood pressure, which is somewhere between these two measurements, the European Society of Cardiology, European Society of Hypertension guidelines recommend lifestyle changes. And the drug treatment should be considered only when the cardiovascular risk is very high because of established cardiovascular disease, especially coronary artery disease. This predicts both the prevalence of hypertension and the control rate among all hypertensive subjects, applying both the 2017 ACC/AHA guidelines as compared to the GNC8. If we look at the bar chart on the left regarding the prevalence, the percentage of normal blood pressure measurements are almost the same in both groups. However, if we apply a tighter control measures or a tighter readings, more patients will be defined as having hypertension, and subsequently on the right side, less patients would be controlled on medications according to the 2017 ACC/AHA guidelines. What is the rationale beyond this? It dictates that the hypertension continues to be the main risk factor producing death and disability, and the risk of coronary events and stroke among subjects with systolic blood pressure between 130 and 139 is almost 2 times higher compared to those who have systolic blood pressure measurements below 120. Although this increased risk attenuates with advancing age, it is still present in older adults. This is confirmed with this diagram that shows that the lower your blood pressure is, the higher the chance you'll be free from cardiovascular event, and the higher the blood pressure or less controlled your blood pressure is, the lower the chance you'll be free from cardiovascular events. On the other hand, the ESH rationale is that there will be no benefit of blood pressure lowering if the initial blood pressure less than 140 or 190 in subject with low to intermediate cardiovascular risk. And many studies of patients with diabetes demonstrate increased cardiovascular risk if blood pressure is lowered below 120/80. Only those with almost 20% or more 10-year cardiovascular risk derive more benefit than harm from aggressive blood pressure lowering treatment. So in a compromise, we could say that physician could apply the ACC-AHA definition only if they modify their habits and start measuring blood pressure according to the SPRINT protocol, which means using an automated device in a quiet room and without any healthcare professional in the room. The famous gold stick or hockey stick chart depicts that or confirms that the lower is the better till you reach the 120/70. After that or below that level, you will start having an increase in the hazard ratio of having complication from lowering the blood pressure below that level. So the lower is the better, yes, but up to a certain extent. Do not go beyond 120/70. This is the comparison of the office, home, and ambulatory blood pressure measurement threshold for elevated blood pressure according to the recent 2024 ESC guidelines. We see that the non-elevated blood pressure, whether it's in office, home, or daytime ambulatory blood pressure, should be less than 120/70. The elevated blood pressure is between that measurements and 140/90 in case of office blood pressure measurements, and 135/85 in home blood pressure and daytime monitoring. Anything above that would be considered hypertension according to the European Society of Cardiology guidelines. The ACC-AHA 2017, which is the latest, by the way, by the Americans to address the hypertension, is making it much easier for you to memorize the number because it doesn't differ according to any category, whether it be the age, diabetes, coronary artery disease, chronic kidney disease, or both stroke. They define the target or the optimal blood pressure to be less than 130/80. Whereas it's a little bit more complicated or individualized according to the European Society of Cardiology, European Society of Hypertension guidelines. How should a clinician implement these recommendations in daily practice? Most of the physicians, they will have an attending nurse with them or a physician assistant. They will take the blood pressure measurement according to the guidelines. This may take something like 7 to 8 minutes, especially if they are repeating this 2 to 3 times, as mentioned earlier. They will review the medication and update them in 3 to 4 minutes. They will discuss with the patient lifestyle modifications and review the current lifestyle changes implemented in the previous visits. This may take up to 10 minutes. Then they will calculate the cardiovascular risk assessment via the application. This may take 1 to 2 minutes. And all this information will be presented to the physician at the visit start. In total, it will take something between 20 minutes to 30 minutes. And most of the physicians, if they don't have an assistant dedicated to this, may not be able to implement this in real life or real practice, if we are saying so. Whether you're having an optimal blood pressure or various stages of high blood pressure or even hypertension, patient age should be considered in defining the follow-up interval. If you're having a normal blood pressure, you should measure your blood pressure every 5 years. This interval is decreasing gradually the more your blood pressure goes up. And once you're in the hypertensive stage, you should confirm the diagnosis with repeated office blood pressure measurements or with an out-of-office method, whether it be the ambulatory or the home blood pressure monitoring. One word about the hypertension-mediated organ damage. If you're suspecting that your patient is having target organ damage or hypertension-mediated organ damage, there are basic screening tests for that, including 12-lead ECG, urine AC ratio, blood creatinine, and the eGFR, and fundoscopy. These tests should be done to all patients suspected of having HMOD. More detailed screening tests are left for the discretion of the treating physician, including echocardiography, carotid ultrasound, abdominal ultrasound, and Doppler studies, pulse wave velocity, ankle brachial index, and brain imaging as well. Based on the presence of HOD, hypertension can be classified into 3 stages: the uncomplicated, the asymptomatic, and the hypertension with established disease. This complicated table just shows us the various risks according to the staging of the hypertension and the previous cardiovascular events with associated risk factors, and the classification of blood pressure as well. You would be having any color from the dark green into the dark red according to your risk. And based on that, we will tailor your therapy and lifestyle changes accordingly. You should start with the lifestyle intervention and consider pharmacological treatment as early as possible. If you are in stage 2 or 3, you should immediately start pharmacological treatment and aim for blood pressure control within 3 months. What sort of medication we're having now on board? We have the single pill dual combination therapy, that's ACE or ARB plus calcium channel blocker or diuretic. We have the triple combination therapy, ACE or ARB plus the calcium channel blocker and the diuretic. And for those with resistant hypertension, we can add spironolactone or other drugs like diuretics, beta blockers, or alpha blockers. One small note about the beta blockers: it's not a first-line treatment for hypertension anymore, and should be considered at any step in case of a specific indication to add beta blocker, like heart failure, AF, angina, myocardial infarction, or for women childbearing periods who are pregnant. These are some of the causes of pseudo-resistant hypertension and true resistant hypertension. For pseudo-resistant hypertension, you should consider poor adherence and persistence on medication, white coat hypertension, the poor measurement method, marked brachial artery calcification, and clinical inertia like inadequate doses or inappropriate combination of blood pressure lowering drugs. For resistant hypertension, check with the patient the behavioral factors like overweight, obesity, physical inactivity, excess daily dietary sodium, and excess habitual alcohol consumption. And of course, you should detect for the secondary hypertension causes as well as the drugs or substance that may increase blood pressure, mainly the non-steroidal anti-inflammatory drugs, among others. One word that we usually face with patients who are coming to ask us, should I take my bell in the morning on open awakening, or I should take it before going to sleep? The HEGIA trial addressed this issue a few years ago. It allocated almost 20,000 patients into either treatment open awakening or treatment at bedtime, with follow-up extending beyond 6 years and analysis based on intention to treat. It showed that bedtime better is better in all aspects related to the total events, the cardiovascular events, stroke and coronary events, and total death, ischemic stroke, hemorrhagic stroke, myocardial infarction, coronary vascularization, heart failure, TIAs, angina, peripheral arterial disease, or occlusion of the retinal artery. These 2 diagrams depict the same findings. One word about the renal denervation, which has been emerging as a treatment option to those patients who are having resistant hypertension. It's still a class 2B, which means that it may be considered, but the evidence is lacking huge randomized controlled trial, and it's still I would say an investigational therapy. Patients should have resistant hypertension that's uncontrolled despite the 3 blood pressure lowering medications, including a thiazide or a thiazide-like diuretic, who express preference to undergo renal denervation after explaining the risk and benefit with a multidisciplinary team. It should not be recommended as a first-line blood pressure lowering intervention for hypertension, and it should not be recommended for patients who are having moderate to severe impairment of renal function. with an estimated GFR of less than 40 ml per minute per meter square, or of course for any secondary cause of hypertension. In summary, both ECC and ECSH guidelines have some similarities and differences. Regarding similarities, both emphasize the importance of home blood pressure monitoring, whether you take your blood pressure at home twice in the morning, twice in the evening, in the week before clinic, and you bring the blood pressure machine annually for validation. Regarding therapy, they both restrict beta blockers for patients with comorbidities or other indications, and initial single pill combination as initial therapy as soon as the patient is indicated for that. Regarding follow-up, they both emphasize on the detection of poor adherence and focus on improvement, and the blood pressure telemonitoring and digital health solutions. Regarding the dissimilarities, we have previously discussed this. There is a difference between various levels of blood pressure target, whether it be in the office, daytime, nighttime, or 24-hour mean or home blood pressure mean, and the overall blood pressure target for treatment and initiation of combination therapy. There is a difference as well in hypertension requiring intervention. The Americans are going for anything above 130/80, while the Europeans will try initial lifestyle modifications and risk factor reduction before considering treatment for any patients who's having blood pressure more than 140/90. Well, that's it. Thank you very much for your attention.
Thank you so much, Doctor, for this amazing presentation and for this informative one. And I guess all the doctors will benefit a lot, because I guess it's from another perspective than we usually hear the hypertension from doctors explaining the hypertension. But we have some question for you, please, if you can answer them. Okay, first of all, there is a question from our audience. For patients with hypertension whose blood pressure has been successfully controlled with medications for a year, is it safe to discontinue the treatment? So they're asking if hypertension can be considered as a completely curable condition.
No. The definite answer is no. Hypertension is a chronic disease unless you're having a secondary hypertension, which means a hypertension related to a cause that is treatable or preventable. Let's say, for example, you're having hypertension related to medication, to alcohol intake, or you're having hypertension due to endocrine problem, for example, and you treat that. Then what you're having is a primary or idiopathic hypertension. You should take medication indefinitely. It's a chronic disease. I always tell my patients that hypertension is like diabetes. You wouldn't meet a patient who is telling you, I have type 1 or type 2 diabetes, I have been on insulin therapy for so and so years, now I'm feeling good and I will stop my insulin. This is not the case. So in hypertension, it's the same. And if we can just say it's like controlling a coil, you're just pressing the coil to control your blood pressure. If you release the coil, everything will go back to the initial blood pressure.
Yes, exactly.
Yeah.
Okay. And another question, a 45-year-old patient with grade 1 hypertension, and she's refusing to take medications. She desires only to do some lifestyle changes. So how do you advise this one?
It's all about patient education and talking and advice, and during the clinic and outside the clinic and all these things. I mean, at the end of the day, you wouldn't be able to force a patient to take medication. And what I've seen during this presentation and outside in our clinics is that medication adherence or poor medication adherence is one of the main causes why most of the patients in the United States and Europe are not controlled. So if this lady is not 100% convinced that she should she should start medication, and then she should continue on this medication on a daily basis, our effort will be futile. At the end of the day, we will start. All patients should start lifestyle modification and aggressive risk factor reductions, weight reduction, physical activity, moderation of salt intake, and all these things. But as we have mentioned, combined, they will just decrease your blood pressure in the range of 5 to 10 millimeter mercury systolic and maybe 3 to 5 millimeters diastolic. This may not be enough. So continuously, whenever you see your patient in the clinic, whenever you see you discuss with the patient the target blood pressure, please emphasize on the initiation and maintenance of medical treatment, and we hope for the best.
Okay. So, what if a patient who has been on the same treatment for hypertension for 1 year and is controlled, does this patient have to change the medications? How frequent should a patient change his hypertensive medications or hypertension medications?
Well, we have a saying in English that it goes about if it's not broken, don't fix it. Which means if this patient is controlled on his antihypertensive medications and he doesn't have any side effects, because some patients will eventually come to you in the clinic and say, this blood pressure is fine, my blood pressure is fine, it's controlling my measurements at home, but for example, I have low lymphedema because I'm taking calcium channel blocker. In that case, you may change the medication. But if the patient is well controlled in his medication, there are no side effects, there is no need to change the blood pressure medication. Again, if it's not broken, don't fix it.
Because we have a misconception about you have to change frequently your medications, because sometimes the medication will not work fine if you take it more than 3 months, 6 months, and so on.
As long as your blood pressure measurements are fine, there is no need to change your medications.
Okay. These were the questions, and we're so happy that we had you today with us on MedSynapse, and definitely we would want more and more from these kind of presentations and discussion with you, doctor. Thank you so much for your time today.
And thank you as well, and I hope the audience enjoyed this presentation.
Thank you, doctor. Have a great day.
Thank you.